Question 1. A 60-year-old patient with a history of chronic smoking and hypertension presents with a sudden onset of weakness on the right side of his body, difficulty speaking, and facial drooping. His symptoms began approximately 90 minutes ago, and you suspect an ischemic stroke. Which of the following is the most appropriate initial management step for this patient? A. Immediate administration of intravenous thrombolytics (TPA). B. Obtain an MRI to assess the extent of the stroke. C. Administer aspirin and monitor the patient for 24 hours. D. Initiate anticoagulation therapy immediately. Answer A. Immediate administration of intravenous thrombolytics (TPA). Explanation: in cases of acute ischemic stroke, intravenous thrombolysis with tissue plasminogen activator (TPA) is the most effective treatment if administered within 4.5 hours of symptom onset. The patient's symptoms began 90 minutes ago, which is within the therapeutic window. Option B, MRI, is useful for imaging but not the immediate management step. CT scans are preferred in acute settings for quick assessment. Option C, aspirin, is used in later management but not for the immediate treatment of an ischemic stroke. Option D, anticoagulation, is generally not used immediately in the acute phase of ischemic stroke unless there's confirmed embolic origin, but thrombolytics are prioritized first. Question 2. In the context of Parkinson's disease, which of the following treatment strategies primarily targets the symptoms of bradykinesia and rigidity? 2 hallmark motor symptoms of the disease. A. Levodopa-carbidopa. B. Dopamine agonists. C. Monoamine oxidase type B inhibitors. D. Anticholinergic medications. Answer A. Levodopa-carbidopa. Explanation: levodopa-carbidopa is the gold standard for treating motor symptoms in Parkinson's disease, especially bradykinesia and rigidity. Levodopa is converted into dopamine in the brain, while carbidopa prevents the breakdown of levodopa before it crosses the blood-brain barrier. Option B, dopamine agonists, are used to treat motor symptoms, but they are often used in earlier stages or as adjuncts to levodopa therapy. Option C, monoamine oxidase B inhibitors, are used to inhibit the breakdown of dopamine and can be helpful in early stages of the disease, but they don't directly target bradykinesia and rigidity as effectively as levodopa. Option D, anticholinergics, are used to help with tremors but are less effective in treating bradykinesia and rigidity in Parkinson's disease. Question 3, scenario-based. Mr. Thompson, a 45-year-old man with a history of hypertension, presents to the emergency department after an automobile accident. He was unconscious for a few minutes at the scene but regained consciousness quickly upon examination. His Glasgow Coma Scale (GCS) score is 14. His CT scan shows a small subdural hematoma. What is the most appropriate next step in the management of Thompson? A. Admit to the intensive care unit for monitoring. B. Perform a follow-up CT scan in 24 hours to assess the hematoma. C. Discharge the patient with instructions to follow up with neurology in 1 week. D. Immediate surgical evacuation of the hematoma. Answer A. Admit to the intensive care unit for monitoring. Explanation: given Mr. Thompson's history of trauma and the presence of a subdural hematoma on CT, the key concern is monitoring for any deterioration in his neurological status, although his GCS is 14, indicating mild impairment. Subdural hematomas can evolve, and close monitoring in the intensive care unit is essential. Option B, follow-up CT scan, may be appropriate, but it is generally done after an initial period of observation in the hospital, not as the immediate next step. Option C, discharge, is not appropriate as Mr. Thompson has a potentially life-threatening injury that requires monitoring. Option D, surgical evacuation, is not indicated at this stage as the hematoma is small and the patient's neurological exam does not suggest imminent herniation or neurological decline. Monitoring is the most appropriate next step before considering surgery. Question 4. A 28-year-old female with no significant medical history presents with a sudden onset of severe unilateral throbbing headache associated with nausea, vomiting, and photophobia. She describes the headache as starting behind her left eye and spreading across the left side of her head. The headache has lasted for several hours and she reports no prior similar episodes. Upon examination, there are no neurological deficits. Based on this presentation, what is the most likely diagnosis and what is the initial management strategy? A. Tension-type headache, treat with acetaminophen and rest. B. Cluster headache, initiate oxygen therapy and consider sumatriptan. C. Migraine, initiate abortive treatment with triptans and antiemetics. D. Acute ischemic stroke, initiate thrombolysis. Answer: C. Migraine. Initiate abortive treatment with triptans and antiemetics. Explanation: the patient's symptoms, including severe unilateral throbbing headache with associated nausea, vomiting, and photophobia, are characteristic of migraine headache. The most effective initial management includes triptans, which are serotonin agonists that help constrict cranial blood vessels, and antiemetics for nausea control. Option: tension-type headache, typically presents with dull bilateral band-like sensation rather than throbbing pain with associated neurological symptoms. Option B: cluster headache, usually involves excruciating pain around one eye, often with autonomic symptoms, e.g. lacrimation, rhinorrhea, and is treated with oxygen therapy and sumatriptan, but the patient's symptoms are more consistent with migraine. Option D: acute ischemic stroke, would present with neurological deficits, which this patient does not exhibit. Question 5. A 72-year-old male with a history of hypertension and diabetes presents with sudden onset of right-sided weakness, slurred speech, and facial drooping. His symptoms began approximately 2 hours ago, and he is brought to the hospital within the therapeutic window for acute ischemic stroke treatment. His initial CT scan does not show any hemorrhage, and a follow-up MRI confirms the diagnosis of ischemic stroke. Next most appropriate step in the management of this patient: A. Immediate administration of intravenous TPA. B. Administration of low molecular weight heparin. C. Intracranial pressure monitoring. D. Start aspirin therapy and monitor for 24 hours. Answer: A. Immediate administration of intravenous TPA. Explanation: for acute ischemic stroke, intravenous thrombolysis with tissue plasminogen activator (TPA) is the most appropriate treatment within the first 3 to 4.5 hours of symptom onset if the patient is eligible and there is no contraindication. This medication helps dissolve the clot causing the ischemia. Option B: heparin is not used in the acute phase of ischemic stroke due to the risk of hemorrhagic transformation. Option C: intracranial pressure monitoring is not indicated in a patient with an ischemic stroke unless there are signs of increased intracranial pressure, e.g. altered mental status, pupil abnormalities. Option D: aspirin is typically used after the acute phase for secondary stroke prevention, but not as the initial treatment in the acute setting. Question 6. A 50-year-old female presents with progressive memory loss, personality changes, and disorientation. She has difficulty remembering recent events, but her long-term memory is intact. Her cognitive decline has been gradual over the past year, and she is experiencing personality changes, including increased irritability. The patient is not able to perform complex tasks, and her family reports that she has difficulty finances. What is the most likely diagnosis and initial diagnostic approach for this patient? A. Alzheimer's disease MRI to assess for cortical atrophy. B. Frontotemporal dementia PET scan to assess for frontal lobe hypometabolism. C. Vascular dementia CT scan to assess for prior strokes. D. Lewy body dementia cognitive testing and dopamine transporter imaging. Answer: B. Frontotemporal dementia PET scan to assess for frontal lobe hypometabolism. Explanation: this patient's symptoms, including progressive memory loss, personality changes, and difficulty with complex tasks, are suggestive of frontotemporal dementia (FTD), which often presents with early personality changes, disinhibition, and language difficulties. PET imaging can help identify hypometabolism in the frontal and temporal lobes. Is characteristic of FTD. Optical Alzheimer's disease typically presents with more significant short-term memory loss and less prominent personality changes in the early stages. MRI may show cortical atrophy but is not diagnostic on its own. Option C: vascular dementia is associated with a stepwise decline in cognition, often with a history of stroke or evidence of multiple infarcts on imaging. Option D: Lewy body dementia involves fluctuating cognition, visual hallucinations, and Parkinsonism, which are not present in this patient. Question 7. A 40-year-old male with a history of hypertension presents with sudden onset of severe back pain, numbness in his lower extremities, and inability to control his bladder. On physical examination, there is loss of deep tendon reflexes in the lower extremities and decreased sensation in a saddle distribution. He is diagnosed with acute spinal cord compression. What is the most appropriate initial management? A. Immediate MRI of the spine and high-dose corticosteroids. B. Immediate lumbar puncture to assess for infection. C. Pain management with NSAIDs and observation. D. Start anticoagulation therapy for suspected spinal cord infarction. Answer A. Immediate MRI of the spine and high-dose corticosteroids. Explanation. In a patient with acute spinal cord compression, especially with neurological deficits like loss of sensation and bladder control, the immediate management involves MRI of the spine to determine the cause, e.g., tumor, herniated disc abscess. High-dose corticosteroids are given to reduce spinal cord edema and prevent further neurological deterioration. Option B, lumbar puncture, is not the initial management step unless there is suspicion of infection, but the patient's presentation suggests compression rather than infection. Option C, pain management and observation, is not appropriate as the patient requires urgent intervention. Option D, anticoagulation, is not indicated unless there is evidence of spinal cord infarction, which is a less likely cause given the acute onset and the patient's clinical signs. Question 8. A 60-year-old male with a history of Parkinson's disease presents to the clinic for follow-up. He is experiencing worsening rigidity and bradykinesia despite being on a stable dose of levodopa. Additionally, he reports new onset of vivid dreams and confusion at night. What is the most likely explanation for his symptoms, and what is the next step in management? A. Levodopa-induced dyskinesia. Decrease the levodopa dose. B. Worsening of Parkinson's disease. Increase the levodopa dose. C. Hallucinations and confusion due to dopaminergic medications. Consider adding an antipsychotic. D. On-off phenomenon of Parkinson's disease. Switch to an extended-release formulation of levodopa. Answer. C. Hallucinations and confusion due to dopaminergic medications. Consider adding an antipsychotic. Explanation. The patient's new symptoms of vivid dreams and confusion are likely due to the dopaminergic medications, which can cause cognitive side effects such as hallucinations and delirium, particularly in elderly patients with Parkinson's disease. The most appropriate management step is to consider adding a dopamine antagonist, such as quetiapine, which is often used to manage Parkinson's disease-related psychosis. Option because levodopa-induced dyskinesia is more likely to cause involuntary movements, not confusion or hallucinations. Option B, worsening of Parkinson's disease, could explain the worsening rigidity and bradykinesia, but the new onset of confusion and vivid dreams suggests a medication-related side effect rather than disease progression. Option D, on-off phenomenon, refers to fluctuations in motor symptoms related to the timing of levodopa dosing, but it does not explain the patient's cognitive symptoms. Question 9, scenario-based. Mrs. Roberts, a 65-year-old woman with a history of hypertension and atrial fibrillation, presents to the emergency department with sudden onset weakness in her left arm, slurred speech, and difficulty walking. Her symptoms began about 90 minutes ago. A, key of her brain is normal. What is the most appropriate next step in her management? A, immediate intravenous EPA administration. B, perform a lumbar puncture to assess for subarachnoid hemorrhage. C, administer aspirin and initiate anticoagulation therapy. D, transfer to a stroke unit for further monitoring and initiate anticoagulation. Answer A, immediate intravenous EPA administration. Explanation. Mrs. Roberts presents with typical symptoms of acute ischemic stroke, despite a normal CT scan. Intravenous tissue plasminogen activator TPA can still be administered within the first 4.5 hours of symptom onset. Option B, lumbar puncture, is not indicated in this case as subarachnoid hemorrhage is unlikely without history of trauma or specific symptoms such as thunderclap headache. Option C, aspirin and anticoagulation should be initiated in the later management of stroke but is not the immediate step in an ischemic stroke. Option D, transfer to stroke unit and anticoagulation is an appropriate part of stroke management, but the immediate action should focus on TPA administration given the time window. Question 10. A 45-year-old male with a history of chronic alcohol use presents with confusion, tremors, and diaphoresis. His wife reports that he has been sober for the last 48 hours but has developed worsening symptoms over the past few hours. On examination, the patient is disoriented to time and place, has a tremor, and is diaphoretic. His vital signs are as follows: blood pressure 159 mmHg, heart rate 110 EPM, temperature 99.5 deg, 37.5 deg. What is the most likely diagnosis and what is the next step in management? A, alcohol withdrawal, delirium, administer benzodiazepines. B, Wernicke-Korsakoff syndrome, administer thiamine. C, hypoglycemia, administer glucose. D, sepsis, administer broad spectrum antibiotics. Answer A. Alcohol withdrawal delirium. Administer benzodiazepines. Explanation. The patient is presenting with symptoms of alcohol withdrawal delirium, delirium tremens, which typically occurs within 48-72 hours of the last alcohol intake. Common symptoms include confusion, tremors, diaphoresis, and elevated vital signs. Benzodiazepines are the first-line treatment for alcohol withdrawal to prevent progression to delirium tremens. Seizures? Option B. Werner-Korsakoff syndrome occurs due to thiamine deficiency, usually in chronic alcoholics, but presents more with confusion, ataxia, and nystagmus rather than the acute withdrawal symptoms. Option C. Hypoglycemia can present with confusion and diaphoresis, but the patient's symptoms are more consistent with alcohol withdrawal rather than hypoglycemia. Option D. Sepsis would present with fever, elevated white blood cell count, and signs of infection, which are not present in this case. Question 11. A 70-year-old female with a history of type 2 diabetes mellitus, hypertension, and hyperlipidemia presents with sudden onset chest pain that started while she was resting. The pain is described as a pressure sensation in the center of her chest, radiating to her left arm and lasting for 30 minutes. Her vital signs are stable, and her ECG shows sense segment elevation in the anterior leads. What is the most likely diet? And the next step in management? A. Unstable angina. Administer aspirin and nitroglycerin. B. Acute myocardial infarction. Administer aspirin, nitroglycerin, and initiate reperfusion therapy. C. Aortic dissection. Initiate Roman antihypertensive therapy. D. Pulmonary embolism. Administer anticoagulation and CT pulmonary angiography. Answer. B. Acute myocardial infarction. Administer aspirin, nitroglycerin, and initiate reperfusion therapy. Explanation. This patient's symptoms and ECG findings, sense segment elevation, are characteristic of an acute myocardial infarction (STEMI). The initial management includes aspirin to inhibit platelet aggregation, nitroglycerin to reduce myocardial oxygen demand, and reperfusion therapy, either fibrinolysis or prime percutaneous coronary intervention, to restore blood flow. Option. Unstable angina typically does not cause sense segment elevation on the ECG and is not associated with the same level of myocardial injury as STEMI. Option C. Aortic dissection would present with sudden onset of severe chest pain radiating to the back and different pattern of blood pressure changes. Option D. Pulmonary embolism usually presents with sudden onset dyspnea, pleuritic chest pain, and hypoxia rather than the classic presentation of myocardial infarction. Question 12. A 35-year-old female with no significant medical history presents with a rash on her face which has been present for the past 2 days. The rash is erythematous, butterfly-shaped, and across her cheeks and nose. She also reports joint pain in her wrists and knees. Her laboratory results show a positive anti-nuclear antibody on an anti-double-strand ed-DNA. What is the most likely diagnosis? A. Psoriasis. B. Systemic lupus erythematosus. C. Rosacea. D. Rheumatoid arthritis. Answer. B. Systemic lupus erythematosus. Explanation. This patient presents with the characteristic butterfly-shaped rash across the cheeks and nose, which is pathognomonic for systemic lupus erythematosus (SLE). The positive on and DNA antibodies further confirm the diagnosis of lupus, which is an autoimmune disease that can affect multiple organ systems. Opshuazal psoriasis is a chronic skin condition with well-defined erythematous plaques, usually found on the elbows, knees, and scalp, rather than a butterfly-shaped rash. Option C. Rosacea causes facial erythema, but it is not typically associated with a butterfly rash or positive antibodies. Option D. Rheumatoid arthritis typically presents with joint pain and morning stiffness, but it does not cause the characteristic rash seen in this patient. Question 13. A 58-year-old male with a history of smoking and chronic obstructive pulmonary disease (COPD) presents with worsening shortness of breath, productive cough with purulent sputum, and a fever. On examination, he has bilateral crackles in the lungs and his oxygen saturation is 89% on room air. A chest X-ray shows infiltrates in the lower lobes. What is the most likely diagnosis and the next step in management? A. Acute exacerbation of COPD. Administer inhaled corticosteroids and bronchodilators. B. Community-acquired pneumonia. Start empiric antibiotics. C. Acute pulmonary embolism. Administer anticoagulation and perform CT pulmonary angiography. D. Lung cancer with pneumonia. Refer for biopsy and start antibiotics. Answer. B. Community-acquired pneumonia. Start empiric antibiotics. Explanation. This patient's symptoms of fever, productive cough, purulent sputum, and bilateral lung infiltrates on X-ray suggest community-acquired pneumonia (CAP). The initial management involves empiric antibiotic therapy tailored to the most common pathogens in COPD patients, such as Streptococcus pneumoniae and Haemophilus influenzae. Option: acute exacerbation of COPD, typically presents with increased dyspnea, wheezing, and sputum production, but it is not usually associated with fever or infiltrates on chest X-ray. Option C, pulmonary embolism, can present with sudden onset shortness of breath and hypoxia, but this patient's productive cough and fever point to an infectious process rather than a thromboembolic event. Option D, lung cancer with pneumonia, is possible, but the acute onset of fever and cough makes pneumonia the more likely diagnosis at this point. Question 14. A 28-year-old female presents with a complaint of fatigue, weight gain, and cold intolerance. She also reports constipation, dry skin, and hair thinning. On examination, her skin is dry and her reflexes are slow. Her laboratory results show elevated TH and low free T. What is the most likely diagnosis and the next step in management? A. Hypothyroidism. Start beta blockers. B. Hypothyroidism. Initiate levothyroxine therapy. C. Graves' disease. Start radioactive iodine therapy. D. Hashimoto's thyroiditis. Start corticosteroids. Answer: B. Hypothyroidism. Initiate levothyroxine therapy. Explanation: this patient presents with symptoms of hypothyroidism including fatigue, weight gain, cold intolerance, and dry skin. The laboratory findings of elevated TH and low free to confirm the diagnosis of hypothyroidism. The next step in management is to start levothyroxine to normalize thyroid hormone levels. Options or hypothyroidism would present with symptoms such as weight loss, heat, intolerance, and tachycardia, which are not consistent with this patient's presentation. Option C, Graves' disease, is cause of hypothyroidism, but this patient's symptoms are consistent with hypothyroidism. Option D, Hashimoto's thyroiditis, is the most common cause of hypothyroidism, but the primary treatment for hypothyroidism is levothyroxine, not corticosteroids. Question 15. A 50-year-old male with a history of coronary artery disease and hypertension presents with severe chest pain radiating to his back. He describes the pain as tearing in nature and reports difficulty breathing. On examination, his blood pressure is 100 to 100 mmHg, and there is a discrepancy in blood pressure between the left and right arms. What is the most likely diagnosis and the next step in management? A. Acute myocardial infarction. Administer aspirin and nitroglycerin. B. Aortic dissection. Initiate Roman antihypertensive therapy and imaging. C. Pulmonary embolism. Start anticoagulation therapy. D. Acute pancreatitis. Initiate supportive care and hydration. Answer: B. Aortic dissection. Initiate Roman antihypertensive therapy and imaging. Explanation: the patient presents with severe tearing chest pain radiating to the back, which is highly suggestive of an aortic dissection. The discrepant blood pressures between the arms are another clue to this diagnosis. The immediate management includes Roman antihypertensive therapy to reduce the shear stress on the aortic wall, followed by imaging, usually C, angiography or transesophageal echocardiography, to confirm the diagnosis. Optional acute myocardial infarction would present with chest pain, but the nature of the pain and the blood pressure discrepancy suggest aortic dissection rather than myocardial infarction. Option C, pulmonary embolism, typically presents with sudden onset dyspnea, pleuritic chest pain, and hypoxia, but the patient's presentation is more consistent with aortic dissection. Option D, acute pancreatitis, presents with abdominal pain, nausea, and vomiting, not chest pain radiating to the back. Question 16. A 40-year-old female with a history of recurrent urinary tract infections, UTIs, presents with dysuria, frequency, and lower abdominal discomfort. Urinalysis shows positive leukocyte esterase, nitrites, and white blood cells. What is the most appropriate next step in management? A. Prescribe antibiotics based on the most common UTI pathogens. B. Order a pelvic ultrasound to rule out a structural abnormality. C. Perform a urine culture to guide antibiotic therapy. D. Advise the patient to increase fluid intake and follow up if symptoms persist. Answer A. Prescribe antibiotics based on the most common UTI pathogens. Explanation: this patient is presenting with symptoms of a urinary tract infection (UT), and the urinalysis shows typical findings such as positive leukocyte esterase nitrites and white blood cells, the most appropriate next step is to initiate antibiotic therapy based on the most common UT pathogens, e.g. E. coli. Option B, pelvic ultrasound is not necessary in a patient with uncomplicated UT unless there are recurrent infections or symptoms suggesting structural abnormalities. Option C, urine culture can be helpful in complicated or recurrent UTs, but it is not always necessary for the initial management of uncomplicated UTs. Option D, increasing fluid intake, can be supportive, but antibiotic therapy is required to treat the infection. Question 17. A 60-year-old male presents with progressive shortness of breath, a chronic, non-productive cough, and weight loss over the past 6 months. He has a 30-pack year smoking history and is noted to have a barrel-shaped chest. Chest X-ray shows hyperinflation and a flattened diaphragm. What is the most likely diagnosis? A chronic obstructive pulmonary disease, COPD. B, pulmonary fibrosis. C, lung cancer. D, tuberculosis. Answer A, chronic obstructive pulmonary disease, COPD. Explanation: this patient's symptoms of progressive shortness of breath, chronic non-productive cough, and weight loss, along with history of smoking and barrel-shaped chest, are suggestive of COPD, particularly emphysema. The hyperinflation and flattened diaphragm seen on chest X-ray are also consistent with COPD. Option B, pulmonary fibrosis typically presents with progressive dyspnea and dry cough, but it is less likely to cause the hyperinflation and barrel chest seen in this patient. Option C, lung cancer could present with weight loss and cough, but it would likely present with more focal finding on chest imaging such as mass. Option D, tuberculosis, would present with chronic cough, hemoptysis, and night sweats, but the smoking history and imaging findings are more consistent with COPD. Question 18. A 55-year-old male with a history of hypertension and smoking presents to the emergency department with sudden onset chest pain radiating to his back. His vital signs show a blood pressure of 106/9 mmHg, heart rate 100 EPM, and respiratory rate 18 min. On physical examination, he has unequal blood pressures in both arms. Chest X-ray reveals a widened mediastinum. What is the most likely diagnosis and the initial step in management? A, acute myocardial infarction. Administer aspirin and initiate thrombolytics. B, aortic dissection. Initiate Roman antihypertensive therapy and order imaging. C, pulmonary embolism. Start anticoagulation and perform CT pulmonary angiography. D, pericarditis. Initiate NSAIDs and observe. Answer B, aortic dissection. Initiate Roman antihypertensive therapy and order imaging. Explanation: this patient's presentation with sudden severe chest pain radiating to the back, unequal blood pressures, and a widened mediastinum on chest X-ray is highly suggestive of aortic dissection. The initial management involved Roman antihypertensive therapy to control blood pressure and prevent further tear propagation, followed by imaging, CT angiography, to confirm the diagnosis. Optional acute myocardial infarction would present with chest pain and elevated cardiac biomarkers, but would not explain the blood pressure discrepancy or widened mediastinum. Option C, pulmonary embolism, is unlikely given the absence of other typical features such as sudden onset dyspnea or hypoxia. Option D, pericarditis, presents with pleuritic chest pain and is not associated with the widened mediastinum or blood pressure discrepancy. Question 19. A 34-year-old female presents with a 3-day history of fever, malaise, and a sore throat. On examination, she has erythematous tonsils with white exudates and tender cervical lymphadenopathy. Her rapid strep test is positive. What is the most appropriate next step in management? A. Prescribe antibiotics for group a streptococcus. B. Recommend symptomatic treatment with NSAIDs. C. Order a throat culture to confirm group a streptococcus. D. Admit to the hospital for Roman antibiotics. Answer A. Prescribe antibiotics for group a streptococcus. Explanation: this patient has acute bacterial pharyngitis due to group a streptococcus gas as evidenced by her positive rapid strep test and clinical findings. The appropriate management is to prescribe antibiotics such as penicillin or amoxicillin to reduce the risk of complications like rheumatic fever and to shorten symptom duration. Option B, symptomatic treatment with NSAIDs, is appropriate for pain management but is not sufficient alone in the treatment of gas pharyngitis. Option C. Throat culture is not necessary in this case as the rapid strep test is already positive. Option D. Hospital admission is not required for most cases of pharyngitis unless there are signs of severe illness or complications. Question 20. A 45-year-old male with a history of alcohol abuse presents with confusion, ataxia, and ophthalmoplegia. On examination, he has a wide-based gait and nystagmus. His serum thiamine level is low. What is the most likely diagnosis and the appropriate treatment? A. Wernicke's encephalopathy. Administer thiamine intravenously. B. Korsakoff syndrome. Start cognitive rehabilitation. C. Alcoholic ketoacidosis. Administer glucose and insulin. D. Alcohol withdrawal delirium. Administer benzodiazepines. Answer A. Wernicke's encephalopathy. Administer thiamine intravenously. Explanation. This patient presents with the classic triad of Wernicke's encephalopathy, which includes confusion, ataxia, and ophthalmoplegia nystagmus. The condition is typically seen in chronic alcoholics due to thiamine deficiency. The appropriate treatment is intravenous thiamine to prevent further neurological damage. Option B, Korsakoff syndrome, is a long-term consequence of Wernicke's encephalopathy characterized by anterograde amnesia and confabulation. However, this patient's presentation is acute, so Wernicke's encephalopathy is more likely. Option C, alcoholic ketoacidosis, would present with metabolic acidosis, elevated anion gap, and ketosis, but it does not explain the neurological findings. Option D, alcohol withdrawal delirium, would present with tremors, agitation, and delirium, rather than the classic neurological symptoms seen here. Question 21. A 72-year-old female with a history of hypertension and osteoarthritis presents with acute onset of left-sided weakness, facial droop, and slurred speech. She is unable to move her left arm and leg. OK of the head reveals no acute intracranial hemorrhage. What is the most likely diagnosis and the next step in management? A. Acute ischemic stroke. Administer tissue plasminogen activator, TPA. B. Subdural hematoma, autoMRI of the brain. C. Transient ischemic attack, TIA. Initiate antiplatelet therapy. D. Bell's palsy, start corticosteroids. Answer A. Acute ischemic stroke. Administer tissue plasminogen activator, EPA. Explanation. This patient's presentation of sudden onset unilateral weakness, facial droop, and slurred speech is highly suggestive of an acute ischemic stroke. The lack of hemorrhage on CT suggests that the stroke is ischemic rather than hemorrhagic. Tissue plasminogen activator, TPA, is the treatment of choice within 3 to 4.5 hours of symptom on. For ischemic strokes, option B, subdural hematoma, is unlikely given the lack of any history of trauma and the CT scan does not show hemorrhage. Option C, TIA, is possible but less likely since TIA symptoms are usually transient and resolve within 24 hours. This patient's symptoms seem persistent. Option D, Bell's palsy, typically presents with unilateral facial weakness but would not cause the associated weakness in the arm and leg. Question 22. A 50-year-old male with a history of smoking and chronic cough presents with hemoptysis, weight loss, and night sweats. A chest X-ray reveals a mass in the right lung. What is the most likely diagnosis and the next step in management? A. Tuberculosis. Start anti-tuberculotherapy. B. Pneumonia. Prescribe antibiotics. C. Lung cancer. Refer for biopsy and staging. D. Pulmonary embolism. Order CT pulmonary angiography. Answer C. Lung cancer. Refer for biopsy and staging. Explanation. This patient has hemoptysis, weight loss, and a lung mass, which are concerning for lung cancer, particularly given his smoking history. The next step in management is to refer the patient for biopsy and staging to determine the type of cancer and its extent. Obstetric tuberculosis could cause hemoptysis, but the weight loss and mass on X-ray make lung cancer a more likely diagnosis. Option B, pneumonia, typically presents with fever, cough, and infiltrates on X-ray, but does not explain the weight loss or mass. Option D, pulmonary embolism, would present with sudden onset dyspnea and chest pain, not a mass or hemoptysis. Question 23. A 25-year-old female presents with a 2-week history of abdominal bloating, early satiety, and nausea. She has no significant past medical history. On examination, she has a palpable mass in the upper abdomen. An ultrasound reveals an ovarian mass. What is the most appropriate next step in management? A. Order a K125 test to assess for ovarian cancer. B. Perform a laparoscopy to remove the mass. C. Start hormonal therapy to reduce the size of the mass. D. Recommend watchful waiting and follow-up in 6 months. Answer A. Order a Ca-125 test to assess for ovarian cancer. Explanation. Given this patient's symptoms, abdominal bloating, early satiety, nausea, and the presence of an ovarian mass on ultrasound, the next step in management is to order Ca-125 test, which is tumor marker used to evaluate for ovarian cancer. Elevated levels of Ca-125 can be suggestive of malignancy, although it is not specific. Option B, laparoscopy, is not indicated as the first step unless there is suspicion of malignancy based on further testing or imaging. Option C, hormonal therapy, is not appropriate without knowing the nature of the mass. Option D, watchful waiting, is not appropriate in the setting of new ovarian mass with concerning symptoms. Question 24. A 60-year-old female with diabetes presents with a 1-week history of fever, chills, and dysuria. She reports frequent urination and a burning sensation while urinating. A urinalysis shows positive leukocyte esterase, nitrites, and bacteria. What is the most appropriate treatment for this patient? A. Empiric antibiotics for urinary tract infection. B. Intravenous antibiotics for pyelonephritis. C. Pain relief with NSAIDs and hydration. D. Hospitalization for observation. Answer A. Empiric antibiotics for urinary tract infection. Explanation. This patient presents with symptoms and urinalysis findings consistent with a urinary tract infection (UTI). The appropriate next step is to start empiric antibiotics based on the most likely pathogens e.g. coli. Common first-line antibiotics include trimethoprim sulfamethoxazole or nitrofurantoin, depending on local resistance patterns. Option B, intravenous antibiotics for pyelonephritis, is reserved for patients with more severe symptoms such as fever, flank pain, or signs of systemic infection, or if the patient cannot tolerate oral medications. Option C, pain relief with NSAIDs and hydration, may be appropriate for symptom management, but antibiotics are needed to treat the infection. Option D, hospitalization for observation, is not necessary unless the patient is severely ill or has complicating factors such as diabetes, immunocompromised status, or signs of pyelonephritis. Question 25. A 42-year-old male with a history of hypertension and hyperlipidemia presents for routine follow-up. His blood pressure is 149 mmHg and his cholesterol is 230 mgl. His father had a heart attack at age 50. What is the next best step in managing this patient? A. Start a statin for primary prevention of cardiovascular disease. B. Increase his antihypertensive medication. C. Refer for a coronary angiogram. D. Order a stress test to assess for coronary artery disease. Answer A. Start a statin for primary prevention of cardiovascular disease. Explanation. This patient has several risk factors for cardiovascular disease, including hypertension, hyperlipidemia, and a family history of heart disease. Based on current guidelines, individuals with elevated cholesterol greater than 109 mdl or those at moderate to high risk for cardiovascular disease should be considered for statin therapy. Primary prevention even without a history of heart disease. Option B, increase antihypertensive medication, may be appropriate if his blood pressure is not well controlled, but the focus here is on cardiovascular disease prevention rather than just treating hypertension. Option C, refer for coronary angiogram, is not necessary for a patient without symptoms of coronary artery disease. Option D, order a stress test, is not the first step in management unless the patient has symptoms suggestive of coronary artery disease such as chest pain or shortness of breath. Question 26. A 28-year-old female presents with a 3-day history of fever, joint pain, and a malar rash across her cheeks. She has a history of positive anti-nuclear antibody on a test and is concerned about systemic lupus erythematosus. SLE. What is the most appropriate next step in management? A. Prescribe corticosteroids for symptomatic relief. B. Order an anti-DNA test to confirm the diagnosis. C. Initiate nonsteroidal anti-inflammatory drugs, NSAIDs, for joint pain. D. Recommend a referral to a rheumatologist for further evaluation. Answer B. Order an anti-DNA test to confirm the diagnosis. Explanation. This patient presents with classic signs and symptoms of systemic lupus erythematosus, SLE, including a malar rash, fever, and joint pain. The anti-DNA test is highly specific for SLE and can help confirm the diagnosis. Options. Prescribed corticosteroids may be indicated in patients with SLE to control symptoms, but the diagnosis should be confirmed first. Option C, initiate NSAIDs, is appropriate for joint pain relief but does not address the underlying disease. Option D, recommend. A referral to a rheumatologist is appropriate after confirming the diagnosis, especially if the disease is systemic or severe. Question 27. A 33-year-old male presents with a painful red eye and blurred vision for the past 2 days. On examination, there is circumcorneal redness, a moderate amount of anterior chamber cells, white blood cells, and keratic precipitates on the corneal endothelium. What is the most likely diagnosis? A. Bacterial conjunctivitis. B. Acute angle closure glaucoma. C. Uveitis. D. Viral conjunctivitis. Answer: C. Uveitis. Explanation: this patient presents with symptoms and findings suggestive of uveitis, including pain, redness especially around the cornea, blurred vision, and anterior chamber inflammation cells and keratic precipitates. Uveitis is inflammation of the middle layer of the eye and requires prompt evaluation to prevent complications. Option equals bacterial conjunctivitis, usually presents with pus and is not associated with the intraocular findings seen here. Option B, acute angle closure glaucoma, presents with severe pain, nausea, and vomiting, and a fixed dilated pupil, but it does not explain the keratic precipitates. Option D, viral conjunctivitis, typically presents with watery discharge and is associated with viral upper respiratory symptoms, not the inflammatory changes seen in this case. Question 28. A 65-year-old female with a history of chronic kidney disease and hypertension presents with severe headache and nausea. On examination, her blood pressure is 200/100 T8G and her fundoscopy reveals papilledema. What is the most appropriate next step in management? A. Start oral antihypertensive medications. B. Administer omen antihypertensive therapy. C. Perform a lumbar puncture. D. Refer to a neurologist for further evaluation. Answer: B. Administer omen antihypertensive therapy. Explanation: this patient presents with hypertensive emergency characterized by severe headache, nausea, and papilledema indicating elevated intracranial pressure. The next step in management is to lower the blood pressure rapidly with Roman antihypertensive medications, such as labetalol or nicardipine, to prevent further end-organ damage. Option start oral antihypertensive medications is appropriate for hypertensive urgency, but this patient is in an emergency situation and needs more immediate intervention. Option C, perform. A lumbar puncture may be indicated if there is concern for meningitis or intracranial hemorrhage, but the papilledema here is more likely secondary to the elevated blood pressure. Option D, refer to a neurologist, is appropriate for further evaluation, but the immediate management of the hypertensive emergency takes priority. Question 29. A 58-year-old male with a history of diabetes mellitus, hypertension, and hyperlipidemia presents with sudden onset right-sided weakness and slurred speech. A non-contrast CT scan of the head is negative for hemorrhage. What is the most appropriate next step in management? A. Administer tissue plasminogen activator (EPA). B. Initiate intravenous antihypertensive therapy. C. Begin oral anticoagulation. D. Perform a carotid ultrasound. Answer: A. Administer tissue plasminogen activator (TPA). Explanation: this patient's presentation with sudden onset neurological deficits, such as right-sided weakness and slurred speech, suggests an ischemic stroke. The next best step is to administer tissue plasminogen activator (EPA) thrombolytic agent within the therapeutic window, typically within 3 to 4.5 hours of symptom onset, to dissolve the clot causing the ischemia. Option B, initiate intravenous antihypertensive therapy, may be required if the patient has significantly elevated blood pressure, but thrombolysis takes priority in the first few hours. Option C, begin oral anticoagulation, is indicated for atrial fibrillation or other sources of embolism, but is not appropriate for an acute ischemic stroke without evidence of embolism. Option D, perform carotid ultrasound, is useful for assessing carotid artery stenosis, but is not the first step in acute stroke management. Question 30. A 45-year-old female presents with shortness of breath, fatigue, and swelling in her legs. On examination, she has jugular venous distension, bibacillar crackles in her lungs, and pitting edema in both lower extremities. An echocardiogram shows ejection fraction of 35%. What is the most appropriate next step in management? A. Start an angiotensin-converting enzyme ACE inhibitor. B. Initiate diuretic therapy. C. Recommend coronary angiography. D. Prescribe a beta blocker. Answer: B. Initiate diuretic therapy. Explanation: this patient presents with symptoms of heart failure with reduced ejection fraction, HFrEF, as indicated by the low ejection fraction on the echocardiogram. The most appropriate initial treatment for managing fluid overload and heart failure is to initiate diuretic therapy, G. furosemide, to reduce symptoms such as dyspnea and edema. Opraquizole ACE inhibitor is an important part of long-term management for heart failure with reduced ejection fraction, but is not the first step in treating acute symptoms. ACE inhibitors should be started after fluid overload is managed. Option C. Recommend coronary angiography may be indicated if there is concern for ischemic heart disease contributing to the heart failure, but is not the immediate next step for managing acute symptoms. Option D. Prescribe. A beta blocker is another key medication for HFrEF, but is usually introduced later after stabilization of acute symptoms with diuretics.